Okay. So, good morning, good afternoon, good evening to all the dear friends and supporters for Proton platform. And we had the great privilege of having Professor Quan Dong Nguyen from Stanford University, Byers Eye Institute there. And I think the people who are attending the call online and those who could not attend the call offline are very familiar with the term Professor Quan QDN in the field of uveitis. Those who are not familiar, I think they are new to uveitis and they probably do not know much about uveitis. So, Professor Wen has been a great mentor, educator for many of us, including myself and many people on this call as well. And he's been a great supporter. So, this is a very, very rare and unique thing about Professor Wen, and he support a lot of young researchers and clinicians. He is very active in various uveitis studies. So a lot of first in human clinical trials are from Professor Van because of his efforts. He led a big imaging research center also there, along with his colleagues there in Stanford. And of course, he's involved in multiple multi-center clinical trial and also been an integral part and mentor of COTS collaborative ocular tuberculosis study. So there are quite a number of achievements about Professor Van, and he's been, besides that, currently the president of IOIS and also the founding president of SAIVO, the Society for Artificial Intelligence in Vision and Ophthalmology. So with that, dear friends, I present to you Professor Van to speak to us on non-infectious uveitis management and macular edema with the local therapy. So, Professor, to you for your talk. Thank you so much for your time. I do understand it's very early in the morning for you, and particularly this Thanksgiving week, which is a big time. And thanks for taking out time to speak to us and enlightening us with your knowledge and wisdom. Thank you so much, Prof.
Yes, good morning, good evening, Rubesh and JB and our guests and friend there. My pleasure to be back online to join the Proton program. Today, I thought that I would concentrate on the local therapy for non-infectious uveitis and macular edema, but also in addition, I'll be sharing with you some of the work that we're doing and some of the molecules that are potentially coming for our use for our patient. My disclosure is listed here. Our university does receive research funding from various groups, and I chair several studies that are working on to look at the role of various pharmacologic agents for uveitis. When we talk about the principle in the management of uveitis, we should recognize the role of local therapy where we can consider topical, regional, or intraocular. The reason why is because this type of therapy can be applied at primary, as we know, or in addition as supplemental therapy in conjunction with systemic therapy in order to achieve the goal of quiescence for our patient. Certainly, many of you are familiar with the visual morbidity due to uveitis, and therefore the goal of treatment when we treat all of this across the globe, the goal is to reduce the ocular inflammation, haze on cell, or to achieve remission of a haze of 0 or zero point 0.5 plus in order to reduce the visual morbidity, and also to preserve the vision for the patient. The guideline that many of us are familiar with and across the globe and agree upon is that we should treat early with corticosteroid followed by tapering to less than 10 milligram a day to avoid the inevitable side effects of steroid. And that's the goal where we want to achieve. And we should try to do this relatively quickly within 3-4 months or so after treatment so that we would not put the patient on the long-term burden of corticosteroid. With adjunctive therapy, therefore, we hope to reduce the long-term need for steroid overall. Again, if you have to keep a patient on a dose steroid that's, let's say, more than 7.5 milligram daily or more than 2 drops of uh, prednisone acetate daily, then you have not yet reached the goal to achieve quiescence without a side effects. So why local immunosuppression? The majority of many clinical manifestations of uveitis are thought to be due to immune response and therefore require treatment with corticosteroid and subsequently immunosuppressive therapy along with anti-infective therapy in that case would be important with this aspect. So even in the case of infective uveitis, one should also remember to control the inflammation after the anti-infectious therapy has been started. The pathogenesis of uveitis consists of ocular inflammation as well as other structures such as choriocapillaris, the retinal pigment epithelium, the retinal vessel, and the optic nerve, among the things that we learn. When we talk about local steroid option, one can think of things that already exist in our armamentarium, such as the intravitreal injection of the dexamethasone inserts in the name of Osidex. We also have regular type of injection of steroid, such as the triamcinolone acetonide in the form of triacin or Kenlock, and we are then, approximately about a decade ago or so, we also, or actually 2 decades now, in 2000, since 2005, 2 decades now, we have the availability in some country of the implant, the fluocinolone acetonide, 0.59 milligram, where we need to suture to the scleral wall that delivers steroid for a period of approximately 30 months. And then we also have the injectable intravitreal insert, the version of that would also with fluocinolone acetonide, but at a much lower concentration in the form of UT in the United States and probably in the form of Iluvien in other countries. And then most recently, within the last 2 years, one see the availability of a suprachoroidal drug delivery in terms of triamcinolone in the term of Xipere, in which we injected through the sclera to the suprachoroidal space that we've seen here. These are some of the local corticosteroid options that we have. In addition, we also have local non-steroidal anti-inflammatory agent. For topical, we have non-steroidal anti-inflammatory drugs such as the NSAID, and for intravitreal, we have the NSAID as well with this aspect. In addition, we also have local immunomodulatory therapy, IMT, with topical, such as cyclosporin, and then when intraocular we have methotrexate, rituximab, and then you also have complement inhibitor being studied right now that also affect or looking at how to block certain complements such as C3 or C5 for the management of uveitis. And then, we also have adalimumab, and then infliximab has also been looked at for this aspect into intraocular availability with this aspect. So now let's take some time to look at some of this agent in discussion. First, a look at intravitreal methotrexate for non-infectious uveitis. This is certainly first introduced for the treatment of intraocular lymphoma. In other words, if you have ever managed patient with intraocular lymphoma, you know that we have the availability of the intravitreal methotrexate to help in conjunction with systemic therapy to treat that. Intravitreal methotrexate also has some evidence to be a benefit in unilateral diseases, especially in cases where phakic steroid responder due to lower risk of increase in IOP and cataract formation. Studies have also shown that intravitreal methotrexate alone, however, may not be adequate to achieve remission and may be used as an adjunct with other form of therapy. This table here, 17, come out from publication in 2016, looking at various studies, this meta-analysis looking at various studies that have been looking at intravitreal methotrexate as a form of control. Most is used in intermediate uveitis and cystoid macular edema has been reported for the use of intravitreal methotrexate. A picture from one of the publications showing that in some cases, this is analytical cases of one case where you see response of methotrexate in terms of improving cystoid macular edema. Now, of course, one remember this is just only one case that was published in this aspect, and there whether or not there's also influence with this, because most likely in this case that we've shown, methotrexate was used in conjunction with other. Regarding resolution of vitritis, again, has been shown in certain case report where patient with intermediate uveitis and vitritis A decrease of vitreous haze, no, also no worsening in the eyes in the literature. In addition, and this is important, and Professor Biswas is on the line as well. So this can also be used in cases where one has been treating, let's say, ocular TB, that Dr. Agarwal and Dr. Biswas quite known for that. And let's say you were to treat tubercular choroiditis, one need to remember that there's a paradoxical inflammatory response, so one need to control that. And intravitreal methotrexate has been used in some cases for this as well. So serial images review the healing of the lesions documented well on fundus photography with subsequently with the use of anti-inflammatory agent, just that intravitreal methotrexate, one can see the healing of this lesion seem to be quite nicely illustrated in the case here. What about the adverse effect of intravitreal methotrexate? If you are going to use it, one needs to remember that the use of this can lead to corneal epitheliopathy that can put, and then we know that, and also in some cases, endothelial toxicity as well. So that is known for this aspect from there. Now, let's move to the next agent, which is intravitreal adalimumab for non-infectious uveitis. So we certainly are quite familiar with systemic delivery of adalimumab through the two studies, Visual 1 and Visual 2, that have been around for almost a decade now with this aspect. So both of these studies have shown the role of subcutaneous adalimumab can be done to treat active inflammation as well as to maintain the anti-inflammatory effect, and also to be used in long-term to provide maintenance for the control of the uveitis. What about intravitreal adalimumab? This is the work from Sophia and Trudy from Greece that published about 15 years ago, showing that we actually can, first of all, can use intravitreal adalimumab formula. Sophia, when she published this, was using the dose 0.5 milligram in 0.05 ml, and therefore she tested for it and didn't find it to be very effective from this aspect. But certainly raised a root concept and showed that you can inject adalimumab, at least in this sort of series, to be safe. Subsequently, a paper coming out like 4 years after that, instead of using just 0.5 milligram, this group from French and Canada also use it, but at triple the amount. So this one was using 1.5 milligram in this case in a smaller amount, and it showed to be good effective with this aspect from there. So since then, a number of us have also been trying this. I myself have used this, but kind of in a much more case-by-case basis, but I need that. I always wanted to be able to consider this to see to conduct a large clinical trial if we have the time to look at this, whether or not we can look at this particular type to see whether we can be beneficial for our patient. Now what about intravitreal infliximab? Certainly many of us have been using infliximab as a form of intravenous delivery for the treatment of the patient with this aspect. What about intravitreal infliximab? Certainly administer infliximab intravitreally will potentially eliminate the systemic side effect, particularly with the secondary opportunistic infection that this type of treatment can lead to. This is a group of colleagues from Greece that have published this thing since 2012. This was a non-comparative pilot study looking at the use of intravitreal infliximab for relapsing uveitis in adamantinosis Behçet disease. And they noticed some improvement in visual acuity. So certainly that for their part, they seem to be effective in some way. And again, this was an off-label use where they were using it, they were mixing it and tried to inject it into the eye with this aspect from there. Now, some reports say there's no ocular systemic side effects. However, there have also cases in which there has been significant retinal toxicity reported even with a low dose 0.05 milligram intravitreal administration of infliximab that caused a problem. And some subsequently paper have shown that at least some case report that showed that there's significant side effect when it was used in non-uveitic entity. For example, in one cases, it was used for neovascular AMD in combination with an anti-VEGF, for example. And another case, I believe, with macular edema that was also used in anti-VEGF and that lead to toxicity. So there was a editorial asking us that should we want to consider this should be done in a much more formal way with proper testing and things rather than just mixing things and injecting the eye that can lead to potential side effects from there. So thus far, we have talked about intravitreal corticosteroid, intravitreal as well for non-steroidal anti-inflammatory drug, and then we talked about methotrexate, we talk about adalimumab, we talk about infliximab. Now let's look at some of this in terms of disease part. Certainly, one of the disease that this type of local therapy can be quite applicable and also beneficial is macular edema. So when we talk about macular edema, this is certainly one of the most common cause of vision loss in patients with uveitis, with more than 40%, usually 40% of the patients with non-infectious uveitis have macular edema. And so that's the macular edema that we at least report in the literature associated with uveitis with this. It certainly can be persist in eye despite control of uveitis. So this is quite important that macular edema may exist and persist in half of the eye with despite the control in uveitis. And as you know, with the sun's classification, macular edema is not considered a sign of uveitic activity, and that's an independent factor there. So we can control the cell, control the flare, but yet we still can have macular edema that is happening in this case from here. In addition, we also noticed that from the MUST trial, multicenter uveitis treatment trial, this aspect from there, 62% of eye treated with systemically need regional injection for macular edema. So despite systemic therapy in the MUST trial, nearly 2/3 of the subject required a steroid injection for the macular edema with this aspect. It is the leading cause of vision loss, and it may observe with all anatomic subtype of uveitis. It's involved complex number of factors, and thus far for therapy, so far we have known that this could be systemic therapy, oral or parenteral, or well, local therapy, where we concentrate on this presentation. So the case illustrated here, coming out from Emilio Dodge from Argentina. This is a 10-year-old male with B27 associated anterior uveitis and intermediate uveitis that have macular edema present in this here, you can see from there. The impact of uveitic macular edema is quite large. In one series, would have about 842 eyes with 529 patients. This, again, with the number generated, very much similar to what we're familiar with, which is about a third to 40% of the cases, and 44% of them have visual acuity of less than 20/60 with this aspect. And what about the risk associated with uveitic macular edema in this large series tend to be age, chronic inflammation, and specific uveitic entity, for example, Buschard chorioretinopathy, adamantitis, Behçet disease, and sarcoids as well. In addition, it is the leading cause of visual impairment of blindness with an eye with intermediate uveitis and posterior uveitis, as we can see. Again, looking at the risk factor for uveitic macular edema, in the literature, it has been agreed on that thing, for example, being a male, older patient with chronic uveitis, that means the relative risk of 8.3 or so versus acute and recurrent. So chronic uveitis, and that's one of the reasons why, for example, cases of chronic anterior uveitis due to B27 associated uveitis or to TNUD, tubercle nephritis and uveitis syndrome. That's another case where you have chronic uveitis, you can lead to the formation of macular edema. And then posterior and panuveitis. In addition, vascular diseases, as well as certain drugs, and this is important to recognize, certain drugs can do that. Certainly topical prostaglandin, and this one have not really been proven, but just some cases report, hence sometimes the hesitation to use prostaglandin, topical prostaglandin in case of the uveitic macular edema. Other drugs include tamoxifen, fingolimod, which is a drug that used to treat multiple sclerosis with this aspect, high-dose niacin, as well as paclitaxel, which is a type of anti-diabetes treatment, and this aspect from there. And then it's also increase the risk of diabetic macular edema in type 2 of diabetes as well with this drug. Now, I have mentioned already the multi-center uveitis steroid trial. This is the MUST study. So this is a study that has been conducted decades ago or so more, and it has published some several data set, including the immediate data point, and then its long-term, and then find the 7-year result. The ocular outcome are comparable. So in this MUST study, they compare on one hand the standard systemic therapy versus the intravitreal steroid implant in the form of the fluocinolone 0.59 milligram, that is the Retisert. So the outcome comparable but seemed to be favor systemic therapy. That was the conclusion. However, the treatment did not appear to be equal on both groups, meaning that during the 7 years longitudinal study, those who were on systemic therapy continue to get systemic therapy throughout, whereas the average number of implant that was placed in the steroid group, in the steroid implant group, was less than 2. And as you recall, I mentioned that the Retisert intraocular implant of fluocinolone 69.59 milligram only lasts at most from 24 to 30 months. And yet over the 2-year period, the average number of the treatment was less than 2, meaning that many patients may have had the implant laid initially, but may not have had as replacement because there was no mandatory requirement. Rather, it's way into the inflammation recur. Where those who were on the systemic therapy continue to receive throughout the 7-year period. In this study, the MUST study, those who were receiving the implant did have a higher risk of glaucoma and cataract formation. And there's also from this study, it did conclude that there was no increased risk of infection in the immunosuppressive patient with that. Regardless of that, the MUST study did show us that the implant, when we use of this, just local therapy with the implant, can have very much similar outcome as systemic therapy in terms of the visual acuity control in this aspect without with the use of local therapy, just at the implant in this case, one certainly eliminate a lot of the systemic side effect that the patient, even though may tolerate, but may not like so much. So this is overall the visual acuity stable, and then the control of the uveitis was also seen to be stable as well. With the implant, as you can see that on the graph A, was able to control the activity much faster, especially within the first few years. We can see in the orange curve. Eventually, the systemic therapy catch up, but if you want rapid control, certainly using the implant would give you just outcome. Now, that's the MUST study. The POINT study is the one that one should also know. This is a study that came out about 6 years ago. This is a study that looked at and asked the question, what route of therapy is best for delivering steroid? Is it periocular, intravitreal, or intraocular with an insert like dexamethasone insert? So this was from the POINT study. Here you see the ability to decrease the thickness from the baseline, and therefore one can see that the intravitreal and the dexamethasone seem to do quite well. Periocular is much less effective. And then when we are to look at the resolution of the thickness, one can also see that if you really want to control well, one should use the intravitreal injection or use the dexamethasone insert in the form of Ostedac, because they get you much more effectiveness in reducing the fluid, in addition to be able to achieve the goal with that. And so many of us have been using the periocular preceptor part of that, but this study points to us that that is not as effective as we like to do. So therefore, that has also helped us to hence show us the power what a clinical trial can do, because it can really help to explain to us what things has not been clear before. And the point study in this aspect of here and here in terms of the intraocular pressure did not show very much a significant change in the intraocular pressure, or very similar outcome among the three routes: periocular, intravitreal, and the insert with the dexamethasone insert. So that's the point study. Now let's come up to another study. This is the merit study. This is a study that look at another important concept to compare intravitreal methotrexate based on some of the data that I showed you before, some of the case series in which one can would be using methotrexate to either help to control the uveitis and or to control the macular edema. Then this is compared to ranibizumab, which is an anti-VEGF therapy agent, which has been shown in some case report to have some ability to control the intraocular macular edema. Then we also have intravitreal dexamethasone implant that can be important as well in this aspect. So this is a trial that looked at 1:1:1 randomization to that. And the result first released a few years ago with this that showed that the patient who received intravitreal dexamethasone is the one that showed the most significantly improvement in visual acuity as well as central subfield thickness. Methotrexate was found in this clinical trial to be ineffective in the ability to control the macular edema, and that ranibizumab on the middle just shows some slight improvement in central subfield thickness, but no effect on visual acuity. So again, one can see the power of clinical trial or clinical study, because each of these individual agents, methotrexate, ranibizumab, and dexamethasone, have been shown used in various cases, and therefore to really understanding its true role when perform a clinical trial. In this case, it does show to us that the methotrexate is very much ineffective in terms of visual acuity and central subfield thickness. Now, one can still use it for other indications, just as intraocular lymphoma, which has been shown to be effective. But when you come to truly uveitis and macular edema, intravitreal methotrexate may not be so beneficial from this study. And then we also learned that the dexamethasone is quite important as well for this treatment. Ranibizumab is an anti-VEGF, but it's one of the weaker one. So one still question, what happens if we use a very effective type of anti-VEGF agent? For example, if we were used to use the high dose of aflibercept, the 8 milligram, would that show a difference for us in this case from there? So then, with this aspect, this table has been made by Professor J.P. Dunn from the Byers Eye Hospital, and J.P. had put together a reasonably good diagram to give you different branch points where to go. For example, if you were to have anterior intermediate uveitis and you were to have the macular edema from that, you can break it down to whether there's IOL related, meaning post-surgical, or it is a pseudophakic macular edema type of thing, or not IOL related in this aspect, whether or not post-surgical pseudophakic or regular not related IOL. And let's go down to the certain branch way in order to help you to understand and give you potential option. So JP did a very nice work in terms of looking at anterior and intermediate uveitis that have macular edema associated with it, as well as to macular edema associated with the posterior and pen uveitis. This table from there. Now, one can now look at how we classify uveitis and uveitic macular edema in terms of various categories. So, for example, if we look at infectious versus non-infectious uveitis, both can lead to the formation of uveitic macular edema. For infectious group, we have things such as toxoplasmosis and tuberculosis that we're familiar with. In terms of non-infectious uveitis, this or sarcoidosis and cases of edematous Behçet disease. So here, both types, both infectious and non-infectious uveitis, can have macular edema develop. Then the next thing one can look at is whether this is systemic or ocular, both of which can also have macular edema. For example, sarcoidosis, a very well-known systemic inflammatory disease, can certainly have uveitic macular edema associated with it. On the other hand, a disease like birdshot retinal choroidopathy, which is mainly a disease of Western patients with this aspect from there. When we have bullshot like this, even though it's a very localized ocular disease, it can also have macular edema associated with it. In fact, macular edema is the leading cause of visual loss in patients with bullshot there. And then the third category that we look at is on anatomic locations based on the sun criteria with this. So here we can have anterior, we can have intermediate, and we can have posterior or uveitis. Even with this type of classification, with the anatomic location, one can still have macular edema associated with it. So thus far, I mentioned to you some of the one that currently in existence and various forms. With that, we talk about the importance of uveitic macular edema. We also talk about how to classify uveitic macular edema based on the type of uveitis, based on whether infectious or non-infectious, systemic or ocular, or to another location. Now, I'm going to take some time to talk to you about some of the local therapy in development for non-infectious uveitis. So these are agents that we currently look at to see whether or not we can be used in the future. The first one we'd like to talk about is the OCS-01 in uveitic macular edema in the current clinical trial called the Leopard study. This is OCS-01. So we have already learned and agreed upon that uveitic macular edema is a very common complication of uveitis. About 40% of cases of intimate posterior uveitis usually have macular edema with this. And again, this another important point that we'd like to re-emphasize again, that even after controlled active inflammation, uveitic macular edema may still persist in about half of the cases, as shown in the MERS trial that you just heard about in this aspect. And that intravitreal steroid is effective but require re-injection, and certainly the potential adverse event of ocular hypertension as well as cataract formation. The other category is post-surgical macular edema. So we break it down into macular edema secondary to uveitis, and the other one is post-surgical macular edema. This occurs in about 2% post-cataract surgery, and it is the cause of post-operative vision loss with respect from this. It can also develop after surgical procedure, posterior segment surgical procedure, such as vitrectomy. There are high risk of patients who tend to develop post-surgical macular edema, and that is diabetes, patient with uveitis, and more than half of the case, 56% of high-risk patients develop significant macular edema after that. Here comes the management challenge, and that is, first, there's no established treatment guideline for this, and it also can be often refractory to current therapy with this. So again, we have the uveitic macular edema. We also have post-surgical macular edema. Together, you may hear the term in the future called MESI, M-E-S-I, MESI, macular edema secondary to inflammation. That come out from one of the pharmaceutical company, which tend to clump these two together, that macular edema from association with uveitis and macular edema associated with post-surgical procedure, so-called MESI, M-E-S-I. But I tend to rather break them down to two different groups because they may not behave similarly. The unmet need is that there's certainly a need for the treatment of this, and we don't have a very clear one with this aspect. So Dr. Schumann, who's come out from Israel, has shown that topical dexamethasone cyclodextrin nanoparticle eye drop in the form OCS-01 can be effective in non-infectious uveitic macular edema. Again, this is, I will show again for you, but this is a topical dexamethasone, but not in the regular format, but rather wrap around a cyclodextrin nanoparticle eye drop from this aspect from here. So this is, for this particular aspect, OCS-01 is a dexamethasone ophthalmic suspension. It has used a proprietary formula called OptiRich formulation of the dexamethasone, in this case 15 milligram per ml conjugated. What are the cyclodextrins? Cyclodextrins or hydrophilic carrier is a carrier, as you can see from the cartoon below, cyclodextrin plus the drug molecule, and then it's coming to this water-soluble complex in the form OCS-01. The trick here is to have this proprietary cyclodextrin so that it can very much wrap around the the drug molecule, and then to allow the molecule here to penetrate from the cornea into the anterior chamber and then exert this action as well to the posterior chamber as well. So we have seen already the result, so-called the diamond study. This is or was a phase 3 double-masked randomized controlled trial of OCS-01 and diabetic macular edema. And here we see that how they treat would have a 6-week loading phase and then a 6-week maintenance phase. So the study was a 3-month study, phase 3, randomized to 2-to-1 in this aspect from there. And with that, uh, in that result, one will be able to look at whether or not this OCS-01, a topical delivery, can result in efficacy in terms of potential for diabetic macular edema. The endpoint here is shown here to see whether or not the gain. And here the results seem to be quite positive because in this study, the Diamond 1 study, there was a gain of 7.2 letter with OCS-01 versus 3.1 per vehicle, and it was quite statistically significant. The other endpoint is the 3-line gainer, which also favored the topical OCS-01 topical versus the patient on the vehicle. And then in addition to that, there's also parallel reduction in central subfield thickness as well with this aspect. So you can imagine a situation where by a patient, let's say have diabetic macular edema, that typically in this era, one would consider an injection, an intravitreal injection of various agents. Now come an option whereby you don't have to give intravitreal injection first, but you can use a topical OCS-01, for example, to see whether it can reduce the fluid. And then for that, we can say, okay, if you reduce it, let's go and use it. And then if not, then you can also add intravitreal later. And certainly by the survey of number of patients, that certainly can be a very uh, attractive option for the patient to try topical first with this aspect from there. Now, certainly one need to make sure that there's no rise in intraocular pressure or no significant rise in intraocular pressure or formation of cataract, which has already been shown to be that has not been. So that is the Diamond 1 study. The Diamond 2 study also on study right now and look at again diabetic macular edema, but this time look for a long-term outcome. So the Diamond 2 has already finished recruitment, so we're looking forward to see the result coming out the later half of the 2026 with this aspect. But based on what we have learned about OCS-01, we start a study called the Leopard study to look at OCS-01 topical delivery into a visual acuity and central subfield thickness reduction in subject with uveitic macular edema, UME, or post-surgical macular edema, PSME. And here we want to do with that. Here we want to look at, again, the reduction in central subfield thickness and whether or not there's corresponding gain in visual acuity at this aspect as well, also as week 12. We involve a number of sites besides Stanford. You see 1, 2, 3, 5, 6, 7 sites here looking at this to see whether or not we would be able to look at that. So this multi-center study is nearly finished up the recruitment already, and we look forward to see the potential outcome from this study there. So that is a topical dexamethasone, which has been wrapped around by a very unique proprietary substance, cyclodextrin, that do for that. The next agent we would like to talk about is the local interleukin-6 inhibitor. And then the first one is the vamikibart here. So the concept of IL-6 inhibition we showed for this almost a decade ago in the form of the Stop Uveitis study, whereby we have demonstrated that the use of systemic delivery of anti-IL-6 in the form of tocilizumab has been able to reduce the inflammation. Certainly we expect that. But in addition, very impressively, it can reduce macular edema very nicely in patients with non-infectious uveitis with and without macular edema from that aspect. Vamikibart is a anti-interleukin-6 monoclonal antibody for intravitreal delivery. This is a recombinant fully humanized IgG2 monoclonal antibody that engineers specifically for intravitreal delivery in patients with ocular disease. It has an Fc region that designed to reduce systemic exposure. It's also have here in this case the fast systemic clearance. So obviously we don't have to worry about potential any potential adverse event from interleukin-6, although that has been quite rare. But in case of this, there's fast clearance from there. The half-life of after intravitreal dosing is about 7 days, and it inhibits both the cis and the trend of the signal pathway. The intravitreal vamikibart is currently in clinical trial for uveitic macular edema and diabetic macular edema aspect. At the recent meeting of the 2025 American Academy of Ophthalmology Congress in Orlando, the result of the phase 3 MEERKAT and SANDCAT trial were announced. And that was, again, the MEERKAT and SANDCAT trial was study that designed specifically for uveitic macular edema, not for uveitis, simply for uveitic macular edema. And of the two trials, at least at the 6-month endpoint, the MEERKAT study did meet the specified primary endpoint, and definitely a statistically significant difference between among the doses of the vamikibart versus placebo, whereas the SANDCAT, on the other hand, did not meet the primary endpoint at 6 months. So it was close, but did not meet it. So MEERKAT did, SANDCAT did not. However, this was only at 6 months, so the sponsor may decide to file, or they may decide to look for the long term. So in other words, what happened at 1 year, which is not always, which is not surprising, because at some cases the differences may not yet be completely realized at 6 months, or that there was a primary endpoint, but the long term it may. So we may still expect to see the vamikibart being approved potentially as the treatment for uveitic macular edema. Again, not for uveitis because that was not studied. However, for macular edema, yes. In addition, I want to also mention to you about KSI 501 and KSI 101. These are novel bispecific antibody polypolymer conjugated targeting both the anti-IL-6 as well as VEGF. So this is a polymer that have several arm in it, for example. So one arm can attack VEGF, the other one can attack IL-6. So provide dual inhibition of VEGF and IL-6, which hope to confer superior normalization. And currently, intravitreal KSI 501 is currently in clinical trial for diabetic macular edema, and KSI 101 is for macular edema secondary to inflammation, so-called MEDSI, that I have mentioned to you about. This is a term that this sponsor creates for us to consider for this aspect. So this trial is currently ongoing, and hopefully one will see some outcome in the near future for this aspect. Then finally, I would like to talk about laquinimod in from the LION study that we currently doing at Stanford as well, with the help of a number of our current team members showed here. So laquinimod, this is a molecule that you most likely have never heard of before. This is first developed by a group called Active Biotech from Sweden. It's a first-in-class synthetic small molecule immunomodulator. It targets the so-called AHR, a real hydrocarbon receptor, in the antigen-presenting cell with this aspect from there. So we know in the body, in the eye, we try to balance between the activation of pro-inflammatory T cell and the activation of regular T cell. We try to maintain a balance because when one is disturbed, then one sees the clinical manifestation of inflammation. So, for example, if you were to control the inflammation, we have to have the regular T cell being the stronger ones and be able to control, and therefore we have to decrease the activation of the pro-inflammatory T cell. So laquinimod very much skew the immune response toward the anti-inflammatory phenotype, so pushing it more toward the activation of the regular T cell in order to provide better control of the immune response. That's the expected goal of laquinimod. We already see oral laquinimod in CNS diseases at the phase 2 and 3 study of oral laquinimod for multiple sclerosis, review a favorable safety and tolerability profile. It serves as an immunomodulator as well as neuroprotective with significant outcome of related endpoint. It does have some potential small adverse events, such as some headache and arthralgia, but overall seem to be well tolerated. Because of that, we discussed and encouraged them to develop a topical anti-inflammation, certainly what that we have seen so far, because we know that topical agent can be quite beneficial either as a primary or used into of the adjunctive therapy. Hence, the topical ocular formulation of laquinimod has been developed by the manufacturer. It's called Active Biotech. And here we want to see what goal of this potential in ocular inflammatory disease as steroid-sparing therapy. So preclinical study of topical laquinimod was quite favorable, showing significant dose-dependent reduction of uveitis and reduced vessel formation as well. And the measurable concentration of laquinimod in the posterior part of the eye were detected. So this is a preclinical study. Based on this, we were asking whether or not we can move forward to having topical laquinimod done. But before that, we have to be able to show in human that they can get to the place where we want the posterior part. So hence we create the line study. We look at the safety and tolerability of the distribution of topical laquinimod in ophthalmic solution, uh, which is an innovative immunomodulator using this formula of targeting the aryl hydrocarbon receptor. So this is a prospective open-label phase 1 clinical trial conducted by our team at Stanford with this aspect. And the criteria here is that they have certain ages and all the subjects need to have been scheduled to undergo partial nephrectomy, and they have to have good pressure with this aspect. What we do is we then look at the 3 different doses of the topical formulated laquinimod, 0.6, 1.2, and 1.8, and then they would receive the laquinimod eye drop for 14 days prior to that. Then subsequently, we have cohort 1 and cohort 2, as well cohort 3, where we use it once daily, twice daily, and twice daily. So basically, we go up into the concentration, and then we want to measure what the concentration of laquinimod is in the undiluted aqueous as well as the vitreous as well as the plasma. So 3 locations, aqueous, vitreous, and plasma. And so the result was quite encouraging there. There's a very nice dose response curve among the 0.6, 1.2, and 1.8, as you can see. So this is the laquinimod concentration in the aqueous humor to show very positive dose response. Then when we look at the vitreous concentration, again, it's also very nicely in that topical laquinimod will be able to show the concentration very nicely distributed here from this aspect. And then what about the plasma? The plasma also as well too, even though is much less from this aspect that we see there. So this is a very nice outcome that we thought to show a very nice distribution of that, which is very nicely to dose response curve from that aspect. And with that, we can see here aqueous, vitreous, plasma concentration, very much dose response. And we also look at the free concentration of the unbound one that we also see. What about the safety profile? So far, well tolerated across the 3 doses. Very comfortable with this. And without any side type of effect, we look at several parameters and it seems to look very nicely. So what have we learned from this line study? That topical laquinimod was quite safe and well tolerated at different doses. Those dependent drug level are very nicely shown, and that the quantification of it are very much at the level what we found to be therapeutic relevant, meaning that even with the topical delivery of this, we get to the vitreous in a very sufficient level to be demonstrated to be therapeutic relevant based on what we have seen from the calculation shown with the systemic administration, for example, and that certainly this study support further investigation of this therapeutic potential in uveitis and other ocular inflammatory diseases with that. So this is one of my favorite slides here. The future of uveitis therapy, wherever you are in the world, seems to be quite bright because we have moved away from not just using corticosteroid, but much more to a target therapy into interleukin-6 inhibitor, TNF inhibitor, as well as JAK1 inhibitor, which I have not touched it on, is also indicators that intravitreal and topical therapy with methotrexate, adalimumab, laquinimod, and OCS-01 all seem to be potentially possible if we interlate further depend with indication, for example, and when do we use this aspect for there. Certainly the goal for any type of therapeutic approach for all of us would be no tolerance to any degree of inflammation because that will be goal in order to achieve complete control of inflammation. And I think this is the goal that all of us who in this field will agree upon. And finally, this is our team from the Byers Eye Institute, the Stanford group. Rupesh has been with us in many of this area and this aspect from here. We certainly thank you for your attention today, and we welcome any of you if you have a chance to visit us at the Byers Eye Institute at Stanford, so spend some time with us if possible. We always welcome colleagues from around the world. Certainly, thank you, and thank you again to Dr. Agarwal and Dr. Biswas and the whole Proton team for having me today. Thank you.
Thank you, Prof, for a very illustrative talk as always, and very educating and very comprehensive. I know the topic was very broad, and to cover it in 45 minutes, it was not that easy. But thanks to educating all of us. So, for those who are on call, will you like to unmute yourself and ask? Chitranjan, I saw the question from you. Will you like to ask yourself?
Yes, sir. Thanks, Professor. Very nice talk. I just wanted to know because we are in India where mostly we use steroid injections for CMEs. So, what are the particular conditions you would like us to start with? Uh, take so many injections you have told other than steroid, or where we should change from steroid to these newer injections? Any clinical conditions, especially in remote parts of the world, you can say small parts in India or something. Yeah.
Uh, Yes, so you mentioned certainly with this aspect from there, topical steroid, let me pick back. Local delivery of steroids certainly is certainly possible and can be effective. You can see in terms of topical and in terms of individual. We know that it does work. We just the potential adverse event from that. So we were trying to do if, like say, if we need to use topical corticosteroid, for example, prednisone acetate, that we have to use it more than 2 times a day, twice a day, that is usually a sign for us that we are not sufficiently controlled inflammation. So therefore, in that case, one would then consider the addition of systemic immunomodulator therapy in order to allow us to take away the requirement of uh, frequent drug of topical steroid. So if you find that you have to maintain the patient on, let's say, more than 2 drops of topical steroid a day to control inflammation, you should say ourselves, this is not well controlled yet. This is maybe the time now for us to be able to add some systemic treatment. You indicated some remote area of that aspect, so certainly that have potential that we have to be able to make sure that we maintain the patient. So I certainly admire your ability to manage the patient in very remote area where they don't have opportunity to have regular monitoring with liver, with renal function, with liver function, that type of thing. But certainly, if it's possible, then we should switch over. Again, using your judgment to see what is safe to have such patient be treated with such treatment. We hope
Thank
that
you,
this
Professor.
many of this topical therapy treatment will soon be available elsewhere in the world as well. Because, for example, this last agent, laquinimod, if that can be there, then certainly we can use it long term because so far we don't see any side effect at all. And so, in my working with any of this group of colleagues in any of the pharmaceutical group, we always encourage them to make it so that if we're going to reach a certain point, they have to make it very affordable and available to patient across the globe.
Thank you, Prof, for a very illustrative and very practical answer to this challenging question because of accessibility issues. And I'm glad that you're looking into it, and then with pharma probably will get an answer to this kind of a challenges. Anyone else? Dr. Ho, you are online. You want to ask, or is there anyone else? Professor Alexandra, you have any comment or any?
No, nice talk, Juan.
Thank you.
Very, very impressive. Thank you so much.
Thank you.
Prof. Alexandra, I wanted to check with you. You are doing some work on adalimumab antibodies. You want to
Yes,
ask any question
yes.
related to that to Professor Kwan? Is that a standard of care where you want to measure the adalimumab antibodies? Because we are not doing that in Singapore.
Yeah, so
So
I don't know if you are doing in all the patients levels of the measure of the levels of antibodies and the level of the medication. I don't know if Dr. Juan are doing this in all the patients because the percentage of the antibodies is quite high. In some patients, there is 9 to 30% of patients developing antibodies.
Yes, so I fully agree. I'm glad that Alexandra and Rupesh bring up this issue. So, in fact, we are looking at it quite seriously in a lot of work we've been doing it. So, we have discovered a finding which is quite interesting. We are looking at patients who've been treated with adalimumab, not only for eye disease, but across the board of all the patient at Stanford to use adalimumab, for example. And what we have learned are something quite very educational. We have learned that patients who have an underlying systemic disease that have potentially can have ocular disease, if they were to have, we have two different groups, one that have systemic disease alone and one that have systemic disease that have ocular manifestation. So those two different groups. And if both of them were to be placed on adalimumab, systemic adalimumab, then those who have ocular manifestation are more likely to develop antibodies to it. So we watch and we can see quite a bit that this is significant. So if you were to have patient on adalimumab and that patient happened to have ocular disease, you need to be watch out for that. To the point where now it is part of our clinical practice that we check the antibody every 6 months to do this. So it's
Okay.
automatically that. So we check it every 6 months, we do that. We do it every 6 months or whenever we see that they're different in terms of the control. So nowadays, sometimes we see the control, suddenly the patient who's been quiet for a while now tend to have recurrent of disease activity. Then we ask ourselves, is it the disease recur or is it the drug effect? So we check for that, of course, when we do that. Also, interestingly enough, in the US, we are some cases now, we are asked to use the biosimilar form of adalimumab rather than the original one. So then sometimes we see that effects as well. But in regard of that, we automatically then check at that time. And then the question you ask is then, okay, so what happened when you check that? So what you can do? So there's several things to that. We also learned that there's certain time that the antibody is also is only transient, Alexandra. In other words, it come and then it go away. So that's one group. However, if they were to persist, then we have several options. At time, we may add a anti-metabolite like methotrexate or mycophenolate to help to decrease the formation, or at time we have to increase the dosage of adalimumab, for example, from every 2 weeks to every week from this aspect from there, in order to
Uh-huh.
counteract of this. And even so, is the approved formula is 40 milligram every 2 weeks, but we have a number of subject a patient where we change it to 40 milligram every week. And we do see that that does help. So we try to ask regard of that. So the point there would be that indeed we can learn and we can act upon if we were to find out that there's antibody formation. So that will be learned from that. And then we're looking at some more that we try to analyze right now for OVO that we hopefully present in Denver next year. But that definitely is something point to there. So to Alexandra's point, it is important to us that to our care that we look at this and we do it, like I say, every 6 months now, so our routine part. We also
Thank
try
you.
to try to also understand to try and probe as well too. For example, we also look at that potential antibody for tocilizumab as well as potential antibody to infliximab as well.
Okay, great. Thank you, Juan.
Thank you
Yes.
once again. I think last question before we wind up. I'm sure there will be a lot of questions also related to this topic. Carlos has put a question on the chat. Is the role of IL-17? Are you working on this agent or anything related to anti-IL-17 or drug?
Yes. So the story of IL-17 is quite interesting with this aspect from there. So 15 years ago, when I was in Baltimore at John Hopkins, at that time we were looking at the first study ever using intravitreal interleukin 17 inhibitor delivered as an intravenous formula. So that was secukinumab. When we look at it at the deliver systemically and intravenous, and it worked quite well in that first phase study. Then it moved into the sponsor decide to, instead of using intravenous of it, they decide to use a sub-Q form of it into IL-17 inhibitor. And that did not work really well in the phase 2 the study that Dr. John Dick from the UK were chairing that session. It did not show the benefit. Then another group from Boston went back and used the intravenous form of it, and it did again show benefit. So right now it's available as a off-label use. So if you want to use it, one can use it an intravenous of IL-17, and in some cases show benefit. However, recently there's a group and a sponsor called Accelerant, and Accelerant was looking at a new sub-Q delivery of a bi-specific anti-IL-17. So this one molecule was supposed to be not only grab only one molecule of IL-17, but two molecules of IL-17 at a time. And it's demonstrated in preclinical study that the sub-Q form worked really well. It can have some concentration with this aspect. Again, we indicate that perhaps intravenous is better, but they insist that sub-Q form was reasonable and comparable. As well, unfortunately, the study also failed to demonstrate beneficial outcome for the patient in terms of sub-Q. So to that question, I would say that IL-17 may have a role, because some cases don't, but some study do not show benefit. However, if you are going to use interleukin-17 inhibitor, in my opinion, you should use it in its intravenous delivery, not as a sub-Q form, because several trials now have failed to show that sub-Q delivery of IL-17 inhibitor can be beneficial.
No, I think, Prof, once again, thanks for very nicely sharing. And in interest of time,
International Federal Bank, your perfect banking partner.
Sorry for that. So in interest of time, we will have to call it a day, and I'm sure you will have a long day to go, as well as once again, we like to thank you very much. And not before we take a group photo, hopefully everyone can switch on their video. Prof, you can probably stop sharing your screen, then we can have people coming. Those who want to take photo with Prof Quan, this is your chance. Very difficult to catch hold of him for the photo. Okay, I try every opportunity.
Everyone from
Yeah.
Singapore, I know
Okay.
it's 11 p.m. over there right now, and we appreciate very much. And I don't know what time in India right now. Professor Biswas is still on the line as well. Is this the same time, JB?
7:30. 8:30.
JB sir, maybe you want to
8:30.
adjust your camera. Your face is not coming, only half is coming. You want to adjust your yeah, better. Yeah, much better. Anyone else want to switch on, or that's it? Okay, we'll take a snap then if no other people are coming. Thank you so much, Prof, and we really appreciate it.
Thank you. Thank you, everyone. We hope to see some of you at the upcoming meeting. Goodbye. Thank you. Bye-bye.
Thank you.
Bye.
Take care. Bye bye.